Dr. Doring, your mic's on mute. Thank you, sir. Thank you. All right. Good afternoon, everyone. Welcome to the meeting of the Maryland Oral Health Task Force. We are meeting today as per the task force vote to have our second meetings or two meetings this month. This will be the first one, and then we will have our standing meeting on the 16th. Today we'll go through our work group report outs from the agenda that we have previously sent around. We will have a discussion of the findings and some questions, and then we have two speakers that will come in at the end of our presentation, or to do our presentations. I would ask again that people keep their mics on mute and use the raise hand function as well as the chat box function to ask questions. I would also note that given that this some folks have proxies in place and that at this meeting will not be holding any votes, but so long as we have a quorum, which we'll do off roll, we will proceed with our meeting. So I'd like to do the roll call of the members of the task force, if we could kick this off.
Okay, I have got the two co-chairs as present. Is Emily Dow here? I don't think I've seen her. Hakan Koyman is here. Hello. Debony Hughes? Don't think so. Dr. Doring?
Present.
Hello. Ricardo Kimbers? I don't think Dr. Kimbers is here. Jennifer Saminsky? Anna Davis? Christy Russell? I believe I saw.
Present.
Yes. MJ Kraska, I also saw. Hello. Jean Carlson, Dr. Carlson, I saw. Yes. Dr. Verma, I don't think I have seen. Jennifer Bremen. Yes. Hello.
Good afternoon.
Mary Backley, I've seen as well.
Good afternoon.
Carol Masden. I've not seen. Dr. Romaine, I believe, is here.
Here, are you able to hear me?
Yes, thank you. Brooks Woodward? I don't think so. Stick Wait? Dean Shiflett, yes. Dean, hello. And Cyril Chez? I have not seen. All right, so we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, which is just a quorum, but you don't need it since you're not voting.
All right, outstanding, thank you, and welcome to Delegate Bagnall. So before we kick this off, Dean Reynolds, would you like to add anything?
Alex, I don't have anything to add, just to simply to thank everyone again for making themselves available.
Again, appreciate everyone's time later in the day on a Thursday. So again, what we will do is we will have our standing meeting coming up here on December the 16th. And at that time, I would like to, I'll give you a little preview. I'd like to take a vote on perhaps having a meeting in January. We're targeting around January the 6th in advance of session, so we can squeeze in a little bit more work before people go to ground on a General Assembly type of activities. So I will be asking the task force for a vote on that, and we will also have other speakers teed up during that time. This afternoon, we will have, after we've had our work group discussion, have two speakers that you see present here, Dr. Chelsea Fossey from the American Dental Association Health Policy Institute, I believe is HPI, as well as Dr. Cheryl Lerner from Care First Blue Cross Blue Shield of Maryland. They will both be providing presentations and some data for our edification and to help our deliberations. Delegate Bagnall, before we go on, do you have anything you'd like to add or? Okay, hearing none, we'll proceed. So the first order of business will be to get a report out from our various subgroups. Each one of you was assigned to a subgroup based on the agenda that we had voted on in previous meetings to try to help to break down the work. And obviously, this is going to be an iterative process. This next hour or so is dedicated to a report out from the group, data requests, larger conversations for all of us to work in a collaborative setting so everyone knows what everyone else is working on. So with that, before I kick it off, I want to open up to the task force members if anyone have any questions at this point on process or procedure. Okay, hearing none. If we could have the pediatric and Lindsay if you, or Tyler or Ellen, if you could let me know if we are missing members of the subgroup that might not be able to report out. We ask that it be about 5 to 10 minutes. The pediatric work group, if you can give a little feedback on what you've been inquiring and where some of your preliminary thoughts are.
So can you guys hear me? Okay. So my name's Hakan Koyman, pediatric dentist, and I have two people in the pediatric group. I believe it's Dr. Anna Davis and Carol Masden. We were supposed to meet last night. We had a scheduled Zoom call that nobody showed up for the Zoom call. I know Anna Davis said that she had an unexpected death in the family and she was going to try and make the call. I would like not to hang anybody out to dry. I don't know. I've emailed Carol Masden on several occasions and I've received no reply for her. So I don't know if she's still on the task force or not. So there's no report from the pediatric committee just because there's been no getting together at this time yet.
We'll circle back with staff to do that with this inauspicious start. We'll move on to the adult group, and Dr. Koyman will get back to you on the folks. And again, for those of you who have had an opportunity to meet, the meetings are going to be each one of the subgroups. Homework assignments have been given out in terms of meeting. Focusing on your particular topic at hand, running it through the wash, as it were, of the different barriers and to care that we want to take into consideration against geography, socioeconomic, what have you, and then have the larger task force weigh in on the lines of inquiry. But we will defer the pediatric report out until the 18th. There we'll go on to the adult subgroup.
It's actually going to be the same for us as well. We haven't had a chance to meet yet, just with our schedules. So we'll have to defer to the 18th as well.
Okay. Disability work group. Hearing none present. Lindsay, do we have
I'm
any?
a member of the disability work group, and there has been no contact amongst group members, so I will make it a point to reach out myself.
Okay. Well, have the elderly, Medicaid, and immigration work groups met? Let's just cut to the chase. Dr. Backley.
Yes, good evening. I am Mary Backley with the Maryland Dental Action Coalition. I am on the Medicaid Population Committee. Other members include Dean Shiflett of DentaQuest, as well as Jennifer Bremen of Maryland MCO Association, and Brooks Woodward of Chase Brexton. We met, had our first meeting last week, where we decided the best approach would be to build a grid. Identify the Medicaid population is very general, obviously. So we identified target subcategories within that population. We took the task to mean the Medicaid population, the existing Medicaid population that have dental. So because adults are also covered by another subgroup. So there is overlap there, but we had a really good first meeting in terms of developing a grid that we think would guide our work, but also be easy for other task force members to read. We when we did the target population, we are going to include the total number of population within each category, and the categories are infants, children, adults, dual eligible, and pregnant people. So we're going to break it down individually within those subgroups on the total number in Medicaid, the benefits that each are currently receiving, and for each subcategory, the barriers that were included in the work plan, the geographic, race, ethnicities, socioeconomic, insurance, workforce, education, and then we're breaking it down by community types, rural, suburban, and urban. And we're going to do the impact on each of those community types for each of those population, whether it's high, moderate, and low. And then we're really going to get into the weeds and do bullet points for each. So fellow committee members, I hope I captured this. If there's anything else you would like to add, please feel free to do so.
Mary, that was perfect.
Thank you, Jennifer. Thanks, Dean.
Thank you.
Thank you.
Any other?
Sorry, we're meeting Monday for a couple hours to really take it to the next level. Sorry about that.
No, thank you.
Thank you all.
Any other work group want to report out?
I have this
Yes.
for the elderly.
Elder group. Elder
Please.
group.
Dr. Doring, Dr. Romaine.
Yes.
I'll let Dr. Romaine take the reins here.
Thank you, Dr. Doring, and thank you to Lindsay, who will be advancing our slides. Our work group looking at the elderly population consisted of Dr. Charlie Doring, who's on the road, and myself. And we're happy and honored, and thank you for the opportunity to inform you on dental access for the elderly population in Maryland. So Lindsay, if you could change the slide. Okay. Who are the elderly in Maryland? The Maryland total population is about 6.2 million, and elderly, or those over 65 and older, comprise 16%, about 626,000 people. On average in Maryland, 8% of people 65 or older are living at or below the federal poverty level. 4.5% live in nursing homes and 2% in assisted living facilities. So that really gives us quite a lot of elderly, 95% plus, who live with us in the community. It was interesting because we were trying to qualify or quantify who are the unserved. And as we were looking, there was one statistic that we found that was related by America's health ratings, particularly for the state of Maryland. It looked at, prior to the pandemic, seniors 65 and older making $75,000 and up, a third of them did not have a dental visit. We know that seniors who don't make that much money definitely struggle more with barriers to care. And that's what we want to go into some today, those on a limited income. Lindsay, if you could advance the slide. So whenever we look at barriers to dental care for the elderly in Maryland, the task force came up with the items on the left to review: socioeconomic, insurance coverage, geography, the racial ethnic issues, the practitioner workforce, and education. What we wanted to do, though, is Dr. Doring and I really wanted to look at the research of what are the barriers to elderly accessing dental care. And we looked to our friends at the ADA Health Policy Institute, in particular, Marco Vujicic, who published the graph that you see to the right in Health Affairs. What he and his colleagues did was asked older adults, why don't they go to the dentist? And the number one reason was cost, like 3 times what any other reason was. Secondly, fear of the dentist, which I think shows us we have a lot of communication, a lot of educating to do. Inconvenient location or appointment time, trouble finding a dentist that accepts their insurance. No original teeth. Actually, 11% of Marylanders do not have teeth. No perceived need for dental care. Many times seniors, if they aren't in pain, will feel like they don't need to have dental care, but they're really, really missing out. Our colleague, Dr. Janet Yelowitz from the University of Maryland School of Dentistry, who's the director of the geriatric program there, said in her new chapter on a book that she's helping to edit on aging, it is not a single deterrent, but rather a combination of barriers that affects care. So we want to look at those in more detail. Lindsay, if you could change the slide. Now, I know in my practice, insurance coverage and cost go hand in hand. There are many, many times whenever I have patients who are about ready to retire, I just had one this week that said, well, doc, this is going to be the last time I see you because I'm retiring, my insurance is going to run out, and I'm not sure whenever I'll be back. So insurance coverage in the minds of seniors really gives them a sense of their ability to go to the dentist and pay for coverage. So as we know, and as I see as I talk to my patients, about 1/3 of patients only know that there's not a dental benefit in Medicare. The other 2/3, that tends to surprise them as they're retiring and they enter into Medicare that there is no dental benefit. Secondly, whenever we look at Medicaid in Maryland, Mary was talking about dual eligibles, and the majority of dual eligibles are actually seniors. We know there's no dental benefit in Medicaid in Maryland, but we do know that Medicaid beneficiaries seek care for NTDCs, that means non-traumatic dental conditions, and emergency departments at 3 times the rate that commercial paying patients do. We know that the 65 and older population is the least likely cohort to be covered by private dental insurance. And those with dental insurance see the dentist 2.5 times more than those who do not see the dentist. So in about 2014, I got to do a paper with the ADA Health Policy Institute that has been included in your packet, looking at Medicaid cost savings and these hospital emergency department visits. So the next slide that I'd like to share with you, thank you, is a look at outpatient dental emergency department cases by age in Maryland. The data for this graph was provided by the Maryland Health Services Cost Review Commission. Since publishing the article in 2014, we've just kept up with the data every year, right? The thing I want to impart to you in this is looking at the population of seniors. We go back to 2009, seniors were comprising about 3% of emergency room outpatient dental visits in the state of Maryland. And whenever we circle forward to 2019, we're up to, I think, 8%. So that group is increasing. The next slide, Lindsay. We could see too that Medicare, which is what is in blue, is increasingly paying for more of those hospital emergency department visits, where a senior will go to the emergency department in pain and get antibiotics and many times pain medications. We also see that Medicaid is paying for a much increased piece of the pot there of these dental emergency room visits. So I think this is something that we need to look at and consider in Maryland. The next slide, please. I think this gives us a lot of opportunity. Whenever we look at the US as a whole, 26% of seniors in the United States have a private dental benefit. Of that 26%, 86% of that benefit is usually administered through Medicare Part C. In the United States overall, approximately 11% of seniors have a public dental benefit through either Medicaid vastly, or some have TRICARE or Veterans Administration. In the US overall, about 63% on average of seniors do not have a dental benefit. So now knowing that frame of reference, how do we compare in Maryland? What are the financing options, knowing that cost is the most important barrier for seniors in Maryland to access care? So what we found out is Medicare Advantage in our state covers about 70,000 people. That's about 13% of the senior population. Commercial plans, this is where we want to get more data. This is where we were asking the National Association of Dental Plans if they could help us by age to determine those 65 and older with a commercial plan. In some states, there are ACA marketplaces that open up the marketplace to seniors, but in Maryland, we don't have that. So we have none of that in Maryland as an option. The uninsured, we're kind of estimating to be upwards of 70%, which would be higher than most other states. Because in Maryland, there is no adult dental Medicaid. As you see, that's zero, and estimates 1 to 2% of TRICARE and vets benefits. Okay. So whenever we look at what seniors are underserved vastly because they are in poverty. As we said before, 8% of Maryland seniors over 65 are in poverty, but in certain places like the city of Baltimore, that'll peak more toward 20%. Where I live in Allegheny County, that's probably 16%. Dorchester County, around 18%. So you can see there's great variability by region in the state of Maryland, looking at poverty and access to care. And I think that's something that we need to consider. We can't just look at the state average. We need to look at pockets where people really, really need help. So let's go ahead and go to the next slide. There are definite racial and ethnic issues in disparities for access to oral health care. Low income and minority seniors are more likely to have untreated caries than high income seniors. 33.5% of seniors living below the poverty line have untreated caries compared to 7% of high income seniors. And we look at 39% of Mexican American and 31.3% of non-Hispanic Black seniors have untreated caries compared to 14.1% of non-Hispanic white seniors. As dentists, whenever we engage with all the diversity of cultures and experiences across the state of Maryland, Maryland dentists now are required to have a cultural competency course in order to be licensed in the state of Maryland. So I wanted to make sure that everyone was aware of that. It's something that we're really looking forward to and we feel it can be a great help. Lindsay, if you could go to the next slide, please. So what this shows is really a need to educate, to make it known that fear and a lack of perceived need for dental care are not serving seniors. We need to educate seniors and their caregivers. Because according to the National Oral Cancer Foundation, age has a direct correlation with oral cancer. It's definitely a risk factor in those 45 years of age and older. We know that as healthcare professionals, dentists play a significant role in their patients' overall health, looking at cardiovascular issues, which are one of the highest healthcare cost areas in our state of Maryland. We know that poor oral health increases the risk of developing heart disease. And we also know that people with periodontal disease are 50% more likely to have a heart attack. Many patients don't believe that they have oral health treatment needs if they have no dental pain and they choose to not visit the dentist. But in a 2017 study, 50% of the respondents had not attended a dentist in over 36 months for the reasons they don't think they have a problem. Why should they need to go? And looking at a 2017 report of the Medical Expenditure Panel survey found that only 16% of edentulous adults 50 years and older reported visiting a dentist in the past 12 months. So this makes me think about an experience that I had in my own office of a woman who was retiring, 65. She said, "Doc, I'm going to retire." make me a denture because my insurance is going to run out. I made her a denture. I didn't see her for 10 years. She comes into my office just after the pandemic, after having been away with her daughter. And she said, wow, you know, my denture is really rubbing. I went to my general practitioner and he said I had a denture sore, but it's not going away. So I wanted to come and see you, but it's tough because I don't have dental insurance. I looked in her mouth and she had an advanced squamous cell carcinoma. She died 3 months later. I see every day in the rural area that I practice in need for more access to affordable dental care, in particular dental insurance. And Lindsay, if you could go to the last slide. I have a very high level of confidence that we can eliminate barriers to dental care for seniors 65 and older, and that doing so would reduce suffering, improve health outcomes, close care gaps, lower the cost of chronic disease management, decrease opioid use that we often see prescribed in emergency departments for dental visits, lower health disparity, and increase health equity. So I would throw it over to my colleague, Dr. Charlie Doring, to add any additional comments.
Thank you so much, Dr. Romaine. Excellent job of putting our thoughts together. I want to echo about the emergency department visits. That is so key because dollars are being spent probably out of Medicare or Medicaid. And when a patient, an elderly patient or any patient goes to the emergency department, they're usually an antibiotic and a painkiller. We do not have general practice dental residents any longer at hospitals. It's very rare. And then they're discharged. And so that visit is very expensive, and those dollars could have been spent in a much more efficient and lower cost way. And one other example is a Mission of Mercy in Baltimore, where we had an elderly lady come in and she had an abscess tooth, which was quickly remedied with an extraction. But in reviewing the lady's health history, she was just recently discharged from Johns Hopkins after a week-long stay, where the doctors couldn't diagnose what was going on. She had an elevated white blood cell, this and that. No one took the time, and this is the education for all the medical field, all the medical professionals. Look in the mouth, because that high white blood cell count could be coming from a tooth infection. And so I can't fathom the amount of dollars that were spent on that for, say, a $300 surgical extraction on a patient. So I know we've got great inroads. And again, I thank Dr. Romaine. You did an excellent job putting our thoughts in the elder care. Thank you.
Task force members have any questions for the Dr. Romaine, Dr. Doring report out from the elderly group?
That was an excellent job. And one of the things that hit me, Alex, and other people on the task force is how a lot of these subgroups of populations overlap with some of the same challenges. So a pediatric case that is in a rural area faces some of the same challenges as a senior does in a rural area. Access to care, having insurance, having the coverage. So that was one of the things I think in our subcommittees that we looked at, is that we looked across the spectrum in terms of the categories, and we broke out certain groups that there was a lot of overlap. And so excellent presentation by Dr. Romaine, but it did resonate with me that there is a lot of overlap between different populations and some of the challenges that we identified on our little grid.
Appreciate that. Dr. Romaine, Dr. Doring, any of the clinicians that are present here, and I doubt it, but I'll ask the question anyway. When an elderly person goes in for the ER visit, obviously using that as a situs of care, most people go to the ER when they have nowhere else to go. Does it happen to be that there's any kind of diagnoses that are more likely to present in the elderly population that drives into the ER than not? Or is it just that, like everyone else, that becomes the place to go when you're in need of medical care immediately?
So Alex, I would say we could find that out. I mean, we've been looking at the same ICD-9 and now ICD-10 codes over all those years. And I think there's about 8 of the most common ones that we've been tracking. So I guess if we wanted to, I think there would be a way to say what is the most common one. As I understand though, oftentimes the coding is done more in the back of the house by a coder. And so I never really, I haven't really looked into that, but it's something that we could look into, I'm sure.
And the reason I ask is if you think about, let's say, this is just a hypothetical, I'm not suggesting that this is an answer for anything, but as oftentimes with any other kind of service that's paid out of a set amount of money, out of a certain pool of money, it relates to a certain number of codes. There's $1,000, $800, whatever the case may be, that may be spent on these specific codes. So someone can come in, receive care for these particular sets of services, and draw down off the amount of money that's allocated for that individual, whether it's high risk, whether it's the demonstration project that we have for the duals, like what was contemplated by Medicare for the purposes, and probably not going to be the Build Better Back Act. And your presentation was very informative to the folks down the 95 to establishing a Medicare benefit for dental. But very similar thought process would be there was a voucher of some sort that Medicare was contemplating it at some point in time. It would obviously relate to a series of codes. It would be on a gigantic debit card. So the cluster of ICD-9 codes and particular services that would be the most germane could be informative, and perhaps some of our speakers can get to that.
A lot of the medical codes would be very non-specific, where dental codes would be specific as to tooth and what the diagnosis is. Typically it's going to be abscess. Was that abscess from dental caries, which is very common in the elderly because of lack of saliva flow, changes in diet, more carbohydrates, less ability to do their home care. So dental caries is certainly a factor. So they may go in and with a diagnosis of a dental abscess, or it could be periodontal, but I don't think in the emergency department they're going to distinguish what that is. But those are the two that I see most often in my elderly patients that I get called into long-term care facilities for.
You know, I think another thing too, to Dr. Doring's point, telling the story of the patient that was actually brought in as an inpatient, that's another area of exploration that I know CMS has data for, that we've put in a data request for in the 65 and older population. So we have not yet received that. But I know whenever we were working on the pilot program legislation, Dr. Natalia Chalmers, who's now head of CMS Dental, did a large amount of research and data search. And I remember the one thing that struck me is in that information, she said that between 2013 and 2016, I believe there were like 13 Maryland adults that died as a result of being inpatient admitted to hospitals. So, you know, we always think about Diamante Driver, but sometimes I'll think about those nameless adults and know that we can do better. So I really hope that that is the case. I think the other thing too, to Dean's point, looking at those rural areas, those are often areas, I know like where I am and on the Eastern Shore, where you have health professional shortage areas. And you also have areas where it's tough to get dentists to come and practice. I know out in Western Maryland on the Eastern Shore, it's not like living, you know, in Columbia or somewhere where a young family, a young person wants to live. So those are additional challenges. And then on the piece in Medicare Part C, I just wanted to add, and how much around the country that makes up 86% of those with private insurance. But in Maryland, in those counties that are rural, Medicare Part C is not offered. I know that's true in Allegheny County and some other counties. So I think there too is a big area of opportunity. I'm really looking forward to Dr. Cheryl Lerner's presentation to learn more about that.
Right. And again, with regard to Medicare Advantage, the rates that pay those plans are set by the feds. We don't contribute to that. It's a completely federal program. So insofar as there's a rate sufficiency for developing networks and for a product like that to be launched, and Dr. Lerner can do, that's CMS and the feds establishing that. We can tie into dual eligible population, but that relates to, and as dual eligible special needs plans start to emerge in the state of Maryland, there may be something where there, but in the fee-for-service population, obviously we have our pilot and so forth, but Medicaid is always going to be the secondary payer for that population. Medicare goes first and then Medicaid will go second. So there's financing conundrums that exist for the elderly population, since Medicare is really supposed to be taking charge in that regard. And hey, maybe we'll be surprised. Maybe something will emerge out of the Build Better Act by the end of the year, and we'll all be looking at a Medicare dental benefit, but I wouldn't be a betting man on that. Dr. Romaine.
Okay, I just wanted to ask you a question, Alex. What are the options in Maryland for having seniors be able to buy a benefit on the exchange? Like, is there something that says that in Medicare you can't do that? Please help us to understand.
So I profess that might be something that we would have to talk to the Maryland Health Benefit Exchange about in terms of that. So that could be a staff request to go back and perhaps have them present about that segment. Remember, the qualified health plans and the marketplace are going to be very specific for the 100 to 400% of federal poverty with the subsidies and so forth. So it's going to be a very niche market that was created by the Affordable Care Act. We can talk about how dental exists in that ecosystem and where there's blocks, if you will, across different products. But I profess that that's not my expertise, but we can certainly go investigate that.
Thank you.
Comments, questions? Okay, did our members of our immigrant subgroup present have a report out for that?
Hi, it's Dr. Carlson here from the Eastern Shore. Hello from over here to everybody. Our group has not met yet. We've just been kind of emailing each other and thinking about when we're going to meet. But I actually have started to do some investigation in the area here as to the immigrant population and their access to care issues and what might be some possible things we can do to break down those barriers. I spent a good deal of time speaking with a couple of people at Chop Tank Community Health, which is a federally qualified health center here on the Eastern Shore. They have several locations, 5 or 6 locations, I believe, at the moment. They told me that there are 3 migrant camps on the Eastern Shore that they try to serve, and apparently there is some transportation that tries to help these people. But they told me that the biggest problem they see right now is that just the education piece, that folks don't really realize they don't understand the importance of dental care to begin with, much less the importance of regular dental care. So that's why we have a lot of people over here using the emergency room facility for dental pain, dental infections. I asked them if there was anything like maybe a van that was if anybody had thought about taking a van to these migrant camps. And they said, yes, they just have recently had a van completely outfitted and it's ready to go. They haven't started to do, at least not when I spoke with them about 2 weeks ago about this, but maybe they have by now. In terms of defining the immigrant population, I would say that I haven't done that, and hopefully we can do that with our subgroup here. But I've also spoken with several dentists in the area, and I was a practicing dentist in Cambridge, which is a very kind of semi-rural to rural area myself, and had a lot of patients come to us that were immigrants that had issues with just understanding the importance, but transportation, But a lot of them, the problems they told me about were just getting the work time, getting away from work to come to a dental appointment. The only times that they really can take care of themselves would be in the evenings or on the weekends. And that when it comes down to it with people in these migrant camps, if they're not working, they're not making any money and they're not able to feed their children. So for these folks, just feeding their children and keeping whatever kind of roof they have over their head is of prime importance. So it feels to me like what we're going to be looking at is maybe somehow going to these people or suggesting ways to go to them, because it's very difficult for the immigrant population in many cases, especially the migrant camp folks, to get to dental care. So I think we'll be looking at that. I think there's a lot to look at, and I look forward to doing this with my other subgroup members. But that's where I am at the moment, where we are.
Here's Dr. Carlson. Are these migrant camps relating to the industries, so poultry industry, Eastern Shore, crabbing industry, temporary types?
No, well, one is related. One, what we call down below in Dorchester County and in southern Dorchester County, is related to crab picking. The other two are in Caroline County, and those are agriculturally related. You have people that that are in these migrant camps that help to pick fruit, pick vegetables, that kind of thing. Yeah, so they're mostly it's agriculturally related there, but there is one migrant camp that we know about that's involved in crab picking. Mm-hmm. So none of them live right in the town of, well, I won't say no immigrants live right in the towns of Easton or Cambridge, but most of them do live out in migrant camps. So, okay. And did that answer your question?
Yes, it did. Thank you. Questions?
Oh, I'm on this subcommittee as well. And one of the reasons that I chose this, because when I was practicing in Prince George's County, which is an urban area, in the health department, we had a significant number of immigrant children that would come in with rampant caries and really no real solution. Many of these children needed to be seen in the OR with no resources. And I agree with Dr. Carlson. It is very important that we are able to educate the parents, because there is a lot of misconception about, what drinks are appropriate. We would see children coming in the morning with their bottles filled with soda. Of course, there's a language barrier, there could be a cultural barrier, but it is so important to be able to, because I saw a significant number of cases like this. And unfortunately, we haven't been able to meet to, gather our thoughts, but I will be able to bring the urban perspective and Dr. Carlson, the rural perspective. So we will certainly be able to come back and report on the 18th of our initial, some more findings.
I just wanted to add, thank you very much, Dr. Hughes. And I just wanted to add to that you just brought back a memory for me. I remember I had a lot of immigrant children coming to me on Maryland Healthy Smiles back since 2009 and after. And I remember the little child that came in with a bottle, and I asked the mother what was in that bottle. And she said, café con leche. The child was 2. There was coffee with a lot of milk and even more sugar. Mm-hmm. And I said, why do you have that in that bottle? And she said, well, when my husband gets home, my husband works in a chicken house. And when he works all night long because they do their work in the dark. Getting the chickens out of the house. And in the morning when he comes home, he's very tired and he needs to go to bed and he doesn't want to hear the baby crying. So what she does is she puts something like this café con leche with a lot of sugar in it, gives that to the child in a bottle, which keeps them quiet. so daddy can come home and go to bed. So that was one of the more poignant
And there's
examples.
so many more stories we can share like that. So that's why it's so important to, and because they aren't eligible also for Medicaid, it, you know, that presents an issue.
Yes. Yes. Yeah. Yeah.
Other questions? Okay, I think at this point we should get ready to turn to our speakers, but I would take note, and I'll switch the agenda around a little bit because I was going to make this announcement at the end. Obviously, one of the things that we are going to have to focus on will be some of our workforce issues that we will probably dedicate, and we'll bring this up for vote in our next meeting here in December for April, May. Workforce, dental therapy, so on and so forth. And a lot of that kind of commingles with some of the issues we were experiencing here in terms of geographic disparity. For those of you who did not see it yesterday, there was a very interesting article in the Wall Street Journal about dentists, veterinarians, and so forth. And the average dental loan was $305,000 and the median income about $164,000. And the number of years necessary to offset the loans to get these professional degrees. And so getting folks to service in areas where they're not able to perhaps make up for their professional studies in a short order implicates geographic disparity. So loan programs that Dr. Hughes has alluded to during her presentations previously should definitely be up for discussion, since we want to kind of expand our potential workforce footprint, and that will implicate a conversation specifically called out in our enabling legislation to talk about dental therapists. So we'll defer that conversation to the spring, but I do want to let you all know that that is something we're going to have to take on right off and dedicate an entire meeting to. Dr. Hughes, please.
And I just want to comment on our current application cycle. And this is definitely something we want to look at, is increasing the benefit that we provide, but we still have, we have no applicants from Western Maryland and only one from the Eastern Shore. So we have to figure out, you know, why, because we definitely need the coverage there. Those are our shortage areas. So within application, a number, we had about 15 applicants, and we just can't reach those regions.
So all you dentists on the Eastern Shore, please send applicants Dr. Hughes' way.
And the Western Maryland.
Western Maryland.
Are you able to go into the dental schools and talk to dental students about this? I think you want to get, that's your target group.
And one of the people for that is Dean Reynolds.
So I know we send the announcement out through the dental board. I don't know, you know, I have given presentations to dental students, informing them of the program. But in terms of, we really only send the announcement out to licensed dentists.
And Dr. Hughes, we can discuss ways to support that.
Okay, great.
Thank you, Dean. Thank you, Dr. Hughes. Any other questions? Okay, with that, Dean, do you have anything you want to add before we introduce our speakers?
Not at this time. Thank you, Alex.
Thank you. So we have two speakers on the docket for today, Dr. Chelsea Fossey from the American Dental Association and Dr. Cheryl Lerner from Care First Blue Cross Blue Shield. They'll both be talking from different perspectives, and again, looking forward to their contributions. So with that, I'll turn it over to Chelsea, if you would lead off, please.
Sure, thank you so much. It's a pleasure to be with you today, and really enlightening to hear the beginning of this meeting. So thank you I definitely want to thank Dr. Romaine. A lot of, I think she could have handled a lot of what I would update on from the Health Policy Institute at the ADA or HPI. But I hope what I have to share today is insightful for your team as you continue your deliberations. Commend the work of the task force, and you clearly have your work cut out for you. Mary Backley, loved hearing the strategy you all are employing as you consider the different needs of segments of the population. Really innovative how you're targeting that. So I hope some of this is helpful today, and would be glad to take part in any future conversation if the work of HPI would be helpful to you all. I'm hopeful that the name HPI isn't new to too many on the call, but we operate sort of like an independent think tank within the ADA. So we don't necessarily align with the directive of the ADA board, which allows our research and what we produce to have a different flavor than what you might often see from the ADA. Our team is made up of economists like Marko Vujicic. Again, I'm guessing that name might be familiar to some, as well as other economists, biostatisticians, behavioral scientists. So a really deep bench of great researchers. And what I'll be sharing today is the collective effort of all of those folks. So today I'm going to go over a few things. I'm glad that what I have today, nothing has directly been referenced yet. So again, I hope this is new. But we did come out with some new research in oral health equity and racial disparities in the spring of this year. In October, we released a few publications on Medicaid related research. And then lastly, we've been working with different states over the past few years at this point to look at the fiscal impact of introducing comprehensive or extensive adult dental benefits in Medicaid. So I just wanted to share some high level findings from that research as well. So we've all seen many depictions of the distinction between equality and equity, and I know that this group is very familiar with it. So of course, we're all focused now on equity being the goal, that, you know, by removing obstacles and providing resources that are tailored to the individual needs of different people and populations, that's what's going to be effective at improving health outcomes, and in our case, oral health outcomes. So we try to bring this lens to the work that we're doing, especially these days. This is the work that was released in the spring of this year, some of which Dr. Romaine had shared in her presentation. So we looked at the racial and ethnic mix of the dentist workforce. We also analyzed that of the dental student body, looking at our pipeline of dentists coming up into the profession. We also looked at dental care utilization by age and by race, ethnicity in the population, and cost barriers to dental care by age and by race, ethnicity. So cost barriers. This is a measure, a percent of the population that is experiencing financial barriers to care. The share of the population that indicates they need dental services, but they aren't getting it because of cost. So up on the top of this slide, we have data for children, and down below, we have data for seniors or older adults. The infographic that's available online, and I will gladly share, also has working age adults as well. So we cover the whole lifespan here. And on each line, we have two different points in time, looking back about 15 years. So we start at 2005, you see there on the left, and then move to the right with data from 2019. And each color line represents a different racial or ethnic categorization in the population. So if you look at the top with the graph representing children, you can see that cost barriers over time have been falling pretty steadily. Those curves are moving down, and the trend is moving down from 2005 to 2019. And that decline was felt pretty similarly by all children, all categories of race and ethnicity. If you look at the dots up from 2019, you can see that the curves are pretty tight relative to the curves you see in the graph below. So the differences in racial categorization are pretty small for children. They're not very wide. And if you squint, they're actually narrowing a bit. So again, for children, cost barriers are falling. However, down below, we see the data for seniors, older adults, and there's a different trend over time. The cost barriers have risen over the past 15 years. And perhaps more importantly, you see that those disparities by racial or ethnic categorization of the population, those disparities are growing. That increase in cost barriers has been felt differently by those of different race or ethnicity. In the Hispanic or Latino and Black populations, we're seeing higher cost barriers than for white populations. And for adults or working age adults, we see the same trends. So the key takeaways here, the cost barriers to dental care have fallen significantly for children, but they've increased for adults and older adults. The racial disparities in cost barriers have narrowed slightly for children, widened for adults, and widened significantly for older adults. And when we look at cost barriers, both by age and by income level, we know that the most commonly cited barriers to accessing dental care all relate to cost, regardless of age or income level. And cost barriers to dental care are higher than for any other type of healthcare service. Here on this slide, we have this broken down by age group, so children, adults, and then seniors. And in the purple in each of these bars is the low income population. Then we have in teal, the middle income population, and in orange, the high income population. Of any age and income group, the low income adults, so look in the middle set of bars, that purple, face the most significant cost barriers to dental care. So here we'll go through a few of our recent research releases that for the most part came out in October. They're about 2 months old now. So we have Medicaid research on reimbursement rates as compared to private insurance state by state. We've looked at dentist participation in Medicaid, and we've employed a more refined methodology for doing so, which we'll go into in a minute. And then we've compared dental care use patterns or procedure mix among privately insured and publicly insured or Medicaid insured children, adults, and older adults. So I'll share the highlights from each of these. Here we've compared reimbursement rates in Medicaid to private insurance state by state. We collected reimbursement rate data from state Medicaid programs, either through publicly available online files or by contacting and working with the Medicaid program directly. We used only Medicaid fee-for-service rates. The managed care reimbursement rates, as you all know, are largely proprietary, and therefore we could not factor them into our analysis. For private insurance, we obtained data from IBM MarketScan. We use the top 10 most common procedure codes, or CDT codes, as most of you here know, among privately insured children, and the top 5 most common codes among privately insured adults to develop this index that was used. And then we compared the Medicaid rate to the average private insurance rate in the state. And here is where we have the state-by-state comparison. So for each state, this map shows the Medicaid reimbursement rate as a percentage of private insurance reimbursement. The number shown is the percentage of Medicaid fee-for-service reimbursement relative to private insurance. Specifically here for child services, but we do have a map for adult services as well. So if we take Maryland as an example here, we see 76.3%. So Maryland's Medicaid reimbursement rate is 76.3% of the private insurance reimbursement rate on average. The states shaded in lighter colors, the light pinks and light purples, have relatively lower Medicaid reimbursement as compared to private insurance, while the states shaded in darker colors, the deep purple and deep pink, have higher Medicaid reimbursement rates as compared to private insurance, relatively speaking. And you can see that there's a pretty wide range here. We go all the way down from 27.8% in Minnesota to 104.8% in Kentucky. Again, we have this both for children and adults online. I'm happy to share it. But what do we take away from this work overall? Child reimbursement rates in Medicaid were on average about 61% of private insurance reimbursement rates across the nation. Adult reimbursement rates in Medicaid were on average about 54% of private insurance reimbursement rates. So Medicaid rates for adult dental services as compared to private insurance still trail those of children, those for children. All right, so talking about dentist participation in Medicaid, I'm hopeful that some folks have maybe seen this infographic in the past or some past iteration of it even prior to this version. But we've been looking at dentist participation in Medicaid for quite some time. One of the shortcomings that many people recognize, including us with this past work, is that we were simply measuring provider enrollment in Medicaid, not necessarily true participation or engagement in the program. We were relying on data that reflected how many dentists in each state or in each of these different segments of dentistry had enrolled as Medicaid providers, but not necessarily were seeing patients. So we've refined that methodology with a new source of data. With this new data at our fingertips, we've been using TMSIS, which is National Medicaid Claims Data. From almost all states, we were able to incorporate in this research. We had some levels of missing data that precluded the inclusion of some states. But what we were able to do is, again, not only look at that enrollment piece, but also incorporate an analysis of the number of patients a dentist was seeing who are covered by Medicaid. And as an example of how this new participation measurement methodology is hopefully helpful to folks across states, here are 3 states as an example. So according to our old metric that we were using, all 3 states represented here would have had 71% participation in Medicaid. So essentially all but that light pink sliver that you see or share that you see on the left side here of each of these bars. But that tells, of course, just a really small part of the story. As you move to the right in each of these bars, going from the very pale pink, the share who are not enrolled, to the light pink who are enrolled but not seeing any patients, then we get into the darker pink and purple, and those represent providers who are seeing more Medicaid patients. That deepest color meaning showing those who have 100 or more Medicaid patients in a year. Again, so all 3 states here had 71% dentist enrollment, but in Vermont, more than a third of their dentists are seeing more than 100 Medicaid patients per year. And in Michigan, only 1 in 10 dentists are seeing more than 100 patients per year. So the level of engagement of dentists with their Medicaid program varies drastically, even when we hold that enrollment constant. And we have this by state, and Maryland's included, and we'll send this report so you have it more easily accessible and more easier to read. But here we've organized the states by the share of dentists who are seeing more than 100 Medicaid patients per year. So we start on the left, those with the greatest share. That includes Vermont, Mississippi, Montana, and then move to the far right where we have those with the lowest share of Medicaid providers seeing more than 100 patients, Utah, Virginia, and Maine. We hope that this is helpful to state advocates, oral health advocates, as they can use more flexible definitions of participation in Medicaid to figure out what policy levers might need to be used to meet state needs. We've this has also enabled us to look at Medicaid participation by other dentist characteristics, as well as community characteristics, practice characteristics as well. So I'll share this as just an example. We have more research coming out on that, hopefully soon. Each bar here represents a different race or ethnicity of dentists. And again, in that very pale pink, that's the share of the share of dentists who are not enrolled. And basically what we find here is white dentists have had the lowest Medicaid enrollment and average participation by Medicaid patient volume, where Black dentists followed by Hispanic dentists lead in terms of enrollment in their programs and treating more than 100 Medicaid patients. I think there's a lot that could be dissected here. I think we're opening up a lot of conversation on racial concordance of provider and patient and the importance of representation of the workforce. So there's, I think, a lot of future research in this area. In the interest of time, I'll provide a quick summary here on this, but we knew that folks might be asking us if we combine the learnings on Medicaid reimbursement and Medicaid participation, what do we learn? So basically, if you are those states that have higher Medicaid reimbursement, are they seeing higher Medicaid engagement? And the punchline here is not really. Our takeaway is that Medicaid reimbursement rates, they're loosely associated with Medicaid participation. We think that this is a case where decent Medicaid reimbursement rates are a necessary but not sufficient aspect of the program to improve participation among dentists. So still very important, but not necessarily the main driver of provider participation. There are definitely other factors that need to be considered. It doesn't all just boil down to reimbursement rates in Medicaid. All right, so switching gears again, this paper, we compared the dental procedure mix or dental care use patterns of beneficiaries who are publicly insured, so essentially Medicaid insured, to those who were privately insured. We used TMSIS data, that national newly available Medicaid claims data for the publicly insured, and then for the privately insured IBM Watson Market Scan. These data are from 2018 and we analyzed by age, again, so children, adults, and older adults. And among adults, we analyzed by the benefit level in place in the state. So we broke down the use patterns of adults who were in states with extensive adult dental benefits, those with limited adult dental benefits, emergency only, and none. All right, so there's a lot going on here, but we'll look just at the top columns here. First, we have children, those who are privately insured in one column, and then those with Medicaid or CHIP coverage following just below in that same circle. Then we have adults ages 21 to 64, again, privately insured, and then publicly insured or with Medicaid coverage. And then the next circle is the older adults, privately insured and Medicaid insured. So if we look just at these circles, so prevention and oral surgery, and we start with children, 38% of services for privately insured children were preventive, 35% of the services for privately insured children, or excuse me, publicly insured children were preventive. Oral surgery services account for 3.2% of services for privately insured and 2.7% of the publicly insured. So for children, we're looking, it's quite similar. These numbers are all quite similar across the publicly and the privately insured. But if we move to the middle column here and look at adults, about 22% of services for privately insured adults were preventive, compared to just 12% for adults with Medicaid coverage. coverage. About 12% of services for the Medicaid covered adults are oral surgery services, while less than 3% of the services for the privately insured are oral surgery. And we see similar trends for the older adults as well. So our takeaway here is that, when we compare the share of services for the by age group and by insurance type, overall, we see that the dental procedure mix among Medicaid insured children is similar to that of privately insured children. But for adults, that's not the case. The procedure mix for publicly insured working age adults and older adults skews more towards invasive services. Our takeaway here is that public benefits programs for adults are financing downstream more invasive treatment rather than the preventive services that would avert the need for that treatment in the first place. All right, and one more chart. So this here shows similar data, but broken down by the level of adult dental benefit in the state's Medicaid program. So emergency only, limited, and extensive. If you look on the far right, that represents those who are privately insured. In states with an extensive adult dental benefit, about 12% of dental services were preventive compared to 22% of services for adults who are publicly insured. While oral surgery services account for just 3% of the case mix among the privately insured adults, oral surgery services made up 10% of the dental services for adults in states with an extensive adult dental benefit, and 23% in states with an emergency only dental benefit. So our takeaway is that even in states with extensive adult dental benefits and Medicaid, intensive downstream services are more common than among adults with private dental insurance. And this, of course, suggests that reforms might be needed even in states where there is extensive dental coverage. Taking all of that into consideration, we know that one of the best policy levers right now to improve access to oral health care for populations most at need is working within the Medicaid program, specifically for low-income adults. We released a white paper in July of this year in partnership with Families USA and Community Catalyst, where we estimated the impact of adding extensive adult dental benefits in the 28 states that don't currently provide it as of 2021. And here's just a snapshot of what the current dental benefit landscape looks like. I'm happy to share this. And so what's factored into this quickly, and again, I'll share the full paper for everyone's viewing as you wish. Prior research tells us that providing adult dental coverage in Medicaid significantly reduces emergency department visits and spending for dental conditions. The cost savings are realized by diverting care to more cost-effective settings. We also know that when adults gain extensive dental coverage through Medicaid, their job prospects improve. And we see that that impact seems to be largest for Medicaid enrollees who are Black. We also know that low-income adults living in states where the Medicaid program provides comprehensive dental coverage are far less likely to experience negative economic consequences stemming from poor oral health. And increased access to dental care is associated with lower medical costs among patients or enrollees with certain chronic conditions like diabetes, heart disease, or, as you all know, for people who are pregnant. So here, just quick snapshot, we estimated that it would cost about $4.64 per enrollee per month total, and that includes both federal share and state share across all 28 states. Our analysis is very likely overestimating costs because our assumptions were conservative. We also did not include, due to data limitations, in this national level analysis, the savings from emergency room cost diversions. So that's not factored in this analysis, while we have done that in single state analyses that we've done in the past. So speaking of those single state analyses, we've worked with a number of different states, and actually they're not all represented here, but we've either built upon past work to refine our analyses. We used more current state level data that was obtained by working with state partners in the past to, again, refine our analysis for more actionable work at the state level when it would be timely for the teams in that state. And we're always eager to work with state partners to do so. So with that, I will pause to see if there are any questions. And of course, I will get this over to Lindsay to share with the group.
Thanks, Chelsea. Appreciate it. Dr. Koyman.
Thank you. Thanks for your presentation. That was really great. I did have a couple questions, though, if you could clarify a couple things for me. Going back to the slides, when you were showing the Medicaid and the fee-for-service reimbursement compared to the percentage compared to commercial dental insurance rates in 2020, I just wanted to know if you can clarify. So I know that the HPI did a study in 2013 and looked at that same metric. And back then, if you look at Maryland, Maryland only, if you looked at the percentage of Medicaid fee-for-service reimbursement as a percentage of commercial dental insurance, it was at 47.8%. Do you know how it increased when the rates didn't increase at all during that time?
That's a great question, and something that we did not do an in-depth analysis of what had changed from that prior analysis that was published. So that's a great point. I mean, we could our analyst on this could look at, you know, what we were seeing. I'm guessing it must be, of course, driven by the private insurance reimbursement rates if you've had no change in the Medicaid reimbursement rates. So we should be able to supply that, yeah, if necessary.
Because we would have to, because I mean, saying that we're at 79.8%, I mean, is just not realistic, because there's no way that the commercial insurance rates have gone down since that time. And since Medicaid rates haven't gone up since 2013, to go from 47.8 to almost 79.8 doesn't quite calculate. So it would be interesting to see where that discrepancy is there and how they're coming up with that figure.
Okay, yeah, no, happy to follow up with you on that.
The other question that I had, when you're looking at the number of white dentists versus non-white dentists that are participating in the program, you gave it as a percentage, but do you also have the raw number as far as how many? Because when you say percentage, you know, it gets skewed a little bit just because I think you're looking at the percentage, but you know, if we're looking at the total raw number of dentists that are participating in Medicaid, you know, that also, because, you know, minorities perhaps are not as well represented in as a greater whole. So it, you know, that statistic would just be a little bit more interesting to see as far as the raw numbers of providers that are providing services.
Yeah, and we do have that. But I think what we're finding in our continued research is that these dentist characteristics are coming through very clearly. So while the raw numbers are interesting, certain segments of the dentist profession are very clearly participating more. So to depict that and showing the share doing so has been the most clear way to do so.
Okay. Is there a way that you could send those numbers just so I could see it too?
We can get in touch. We'll need probably to go back to our programmer. So, but if please reach out and we can explore that.
And then I just had one last question. In the one slide that you showed about even in states with extensive medical or Medicaid benefits, that you're still seeing that even though they have extensive adult benefits in Medicaid, that you still have not seen a shift in preventive services that are being used by adults. Is that correct? That they're still only going for emergency care?
No, well,
because it's still at 11%, even in the states that have extensive benefits.
Sure, I wouldn't go as far to say that there's not that enrolled adults are not seeking preventive care. That we do see increased utilization of services even among even in those extensive states. So there's definitely, you know, more utilization. It's not as high as a lot of state representatives often think when we do the state level analyses. It's more like close to 30% of adults will use a benefit, but we are still seeing that share that it's more invasive service, that share of services being more invasive versus preventive.
But and sorry, I'm not trying to be, you know, I just want to be clear, because in the like in one of the very first slides you showed, I think it was at around 11% of seniors or adults use some sort of preventive benefits. And then, but in the extensive states that have extensive Medicaid dental benefits, it was still at 11%, correct?
Yes,
okay.
Yes, on that slide.
So
yeah.
that metric hasn't moved.
No, not, yeah. I mean, our takeaway is like, even in the extensive states, there's more work to be done to get people into preventive care.
Okay. Thank you for taking my question. Sorry, it was so long.
No worries. Thanks.
Before I'm going to go on to Dr. Hughes here in a moment, but one thing I will make note of, two things. The data point in Chelsea's presentation that the 70% participation rate in Medicaid is pretty much akin to what we see on the somatic side, non-dentist, 69, 70%. It's obviously lower than that in Medicare, which is usually 90% with assignment, but that's obviously because of difference in reimbursements a little bit higher, but that's a pretty good number for dental participation as compared to other types of clinicians. And then the last point I want to make is that in a future conversation, for those of you who are read this, I'm sure a number of you do, the Journal of the American Dental Association had a interesting article, I think recently, that shows the lifetime usage of dental services across by kind of lifetime, right? Young, adolescent, adult, elderly, and we will have the lead author of that from the CareQuest Institute coming to speak about that. So we take it as a holistic span of what's good for kids. Doesn't end, dentistry doesn't end. You start with your teeth, you end with your teeth, and so you have to have a continuum of care along the way, and that impacts different payers, different providers, and so forth. And that becomes the rub. Dr. Hughes.
Okay, quick question. You had one slide that showed that there's no real distinct correlation between dentist participation and reimbursement rates. So what other factors do you look at that would cause participation or non-participation?
Great question, and I wish we had the answer. I mean, I think a lot of it, you know, the other major thing we hear all the time is administrative burden, but I think that's often cited at, well, surely administrative burden is a major challenge. I think it often is one of the kind of fallback pieces of rationale that's used for not participation. We don't have data on that, unfortunately, but wish we did.
Other questions from the task force? Okay, thank you, Chelsea. I appreciate the presentation. And again, this is gratis from the ADA, so thank you for doing this for us. I will now turn over to Dr. Lerner from Care First Blue Cross Blue Shield, who will talk about some of the social investments and work they make vis-a-vis the grant making program in particular areas. And I will turn it over to her to make that presentation.
Awesome. First of all, this group is a huge brain trust. And I can't tell you how happy I am to actually be working with you guys as best I can. I want to just put it out there that I am not the expert on all of our products and programs, but I have been talking to those who are, and they are all ready to take any questions back if I can't answer them for you. So again, thank you for your time, and let's kind of just go right into it. All right, so what I was asked to discuss today, and I'm happy to do, is the funding that CareFirst provides. Some of the dental products we have for both commercial and government programs, and let's see where this conversation leads us. I was super, super impressed with HPI, as always, with the kind of research they do. So if I can provide any information today, great. And if I can provide it in the future, I'm happy to connect back with you. So the first group that I spoke to internally was our Community Health and Social Impact Department. Now, this department is relatively new. It's a couple years old. We've decided to pull that out of generally the granting program. This is specific in the health services area. So it's really focused on making sure there's access to care and that care is actually delivered. So the Missions of Mercy, for example, are one of the big granting groups that CareFirst Community Health and Social Impact area takes care of. And again, this has been new. I've had a lot of discussions with the people who work in that group, and they fully understand and empathize and absorb the need for oral health care across the state. And they have been everything you could want in a group where they want to ask questions and want to really feel it. And they've even gone to be present at some of the Missions of Mercy to get the feeling of what goes on, and they understand the beauty of all the donated care that's there. So as you can see, the graphic that they provided me shows you all that they're looking for. There's a big emphasis, as there is in many places, on the social determinants of health and diversity, equity, inclusion, making sure that everybody gets what they need, because we understand at a whole health company that the cost of total care can be impacted positively or negatively by dental care. So that's an awesome and important thing to understand. Okay, next slide. These are from 2018 to present. These are the dental grants and other funding sponsorship opportunities that have been taken on by CareFirst. The pandemic put us in a little bit of a tailspin, as you can imagine, especially with providing funding for the Missions of Mercy, which did not happen during most of COVID, but they're coming back up again. So there was a grant provided for that was to span a couple of years. And Dr. Romaine and I work really hard with them to make sure that we get that kind of money for the Missions of Mercy. So this just gives you a sense of all the things that are going on in the community. And we're talking about a healthcare company, so medical usually takes front stage. We still have a lot of impression that dentists make on CareFirst, and I try really hard to advocate for that. And so anything that comes out from this task force, I'm going to take back with me, and I'm sure I'll have some help, and we will see what we can do to get even more done. Okay, the next slide. I think one of the questions that came up tangentially was, how do we make sure that the money that's funded really gets to the people who need it? So I had a chat with the director of the programs, and she gave me these steps that were taken to make sure that all of the grants and the other kinds of funding were being used as appropriate and used as reported when the application was made clear. When I did talk to her, I asked her, do you have those back-end reports to show how many services were done? What was the level of patient satisfaction? What was the level of volunteer satisfaction? How did it impact qualitatively and quantitatively? And they said that was a gap that they had noticed, and they wanted to work on it. And they were very open to hearing what kind of metrics would be good for a group such as this task force or even the state government. What would be good to know from these grants that are out there? And while I agree that's really important, I don't unfortunately have any information beyond this to share with you, except that the grants continue to repeat. So they're clearly doing what they're supposed to be doing, but we don't have it as qualitatively tracked as we would like to. So anybody who wants to help create these kind of metrics that would be very visually helpful when we have discussions about it, that would be fantastic. Please contact me about that. And now the next slide just gives you the website. If you have some kind of project that you would like to get funded and it relates to social determinants and access to care and overall health outcomes and the quality of life for people who can't otherwise get it, this is the way to do it. I mean, you can certainly tell me and I will pass it on in prose, but this is the way to make the application. And it is a process and it goes up through the board of directors through Care First. So I would be happy to advocate for any dental project that comes about. Okay, so any questions on the funding? I know it was kind of short, but that's really what it's all about.
I have a quick question. Is that funding that you just showed, the list of organizations that were funded, that's for medical, any medical care across the board, or is that specific to dental care?
I asked them for dental only for this one.
Okay, thank you.
It was a filtered list, so there's plenty more on the medical side. There's been an incredible outpouring of funding during COVID especially, and there's been serious outreach to the Hispanic community has been a big target. I've mentioned to them that the Eastern Shore and Western Maryland are areas where there's just huge disparities where we need a workforce. We have discussions, I would say, kind of ivory tower discussions that might start as ivory tower and hopefully become something, such as what can we do to train high school kids who may not have a way to go? Maybe we show them working in healthcare is the way to go. How do we do that? We've tossed this around, and it was quite the discussion before COVID, and then with COVID not being one in the office and getting used to working remotely, and also just trying to get through COVID as a healthcare company to take care of the community, kind of overstepped some of the issues we were talking about with dental. But I think we can start it all back up right after the first year of the year again, and they're prepared to talk about it. So it's awesome. That's a good question, Christy. Thank you. Anyone else? Okay. Diane and
sorry, Dr. Lerner, I have my hand raised.
Oh, I'm sorry.
That's okay. I just wanted to know, do you know what the total dollars are of those grants in Maryland?
I saw it briefly. It was pretty high up there to the $1 million-ish level, but that was over a 3-year period. It was close. It didn't hit over $1 million.
So close to $1 million over 3 years.
Mm-hmm.
Okay. Thank you.
I actually have one follow-up question if nobody else is asking. So for the organizations that receive the grants, the funding goes directly to the organization and then it goes to the provider, or does the funding go to a specific provider on behalf of an organization? How does the funding flow work?
I would like to get back to you on the details, but all of the applications that I saw were organizations and not individual providers. So it would be, for example, the Missions of Mercy. You know how the Maryland State Dental Association Foundation organizes the Missions of Mercy, so they get the money and they dole it out appropriately for the needs.
Thank you.
Okay. All right. Excellent. Feel free at any time. Now I thought I'd just give you an overview of the products and plans. And the important message here is that there are opportunities and options for people, but you do have the financial side of it that needs to be taken into consideration, which is what this task force, a lot of what this task force is looking at. So I just wanted to give a general overview and know that there are available plans, but as we all discussed before, the education of understanding how it is important to get the plans is really what we have to tackle. I know that we have covered individuals who have the option to add dental to their medical plan, and it's very inexpensive, and it's really a matter of, well, I don't think I want to spend $10, $15 a month, which is unfortunate. So I think there's a lot of education that can be done. That's my personal opinion out there. So let's go to the next slide. So this is just Care First information. It's general throughout the insurance industry, but there are usually plans that have a higher reimbursement to the dentist than others. And in the Care First world, that would be traditional, allows people to go to any dentist. PPO, which is the fastest growing plan and sometimes the only plan that anybody considers, where there's a greater discount to the submitted fee that the dentist submits. And then the EPO, which is an exclusive provider organization, which does not allow any out-of-network benefits. So if the dentist is not contracted with the company, the patient doesn't have any kind of benefit. Both of those seem to be more popular, but PPO by far the most popular. And that is a commercial plan. A lot of the other plans are based on it, so it's good to understand that to some degree. Government programs that we have are relatively new into the Medicare Advantage world and also the Medicaid world. About a couple of years ago, we started looking into developing Medicare Advantage and rolled it out in 2021. I was fortunate to be part of the discussion group that wanted to put dental in as an embedded benefit with the minimum benefit of preventive care, the minimum. And then there's also some higher level versions. Medicaid, we acquired the university system, and it's now called Care First Community Benefit Plan, Maryland. So we do own it, but on the dental, it's vendored out through SkyGen, as it was before. Nothing has changed with that. So we don't really have much input into that at all. But the Medicare Advantage, we were able to make sure there was good, solid dental benefits in there. So next slide. Again, we have the large and small group commercial. Employers buy it, any size employers. It could be the state employees. It could be a company. Individuals can purchase on and off the exchange. There are dental programs for them. And of course, sometimes there's subsidies for those, depending on the level of income. They do have on the medical plans some pediatric dental embedded essential benefits, and that does include orthodontics for super handicapping malocclusion. So it's really this similar criteria as there is for Medicaid. So I would say that the orthodontic benefit is probably, it's no different than Medicaid, but at least it's available. Medicare Advantage, we have a spectrum of dental coverage, which I'll show on the next slide. And again, Medicaid is through the Care First Community Health Plan that is doing the Maryland Healthy Smiles program. Okay, next slide. So here gives you just a sense of the Medicaid. It's pretty comprehensive. I imagine many of the dentists on this task force are familiar with it. It's comprehensive. The hardest part is getting the access to care. So again, this is something that SkyGen is administering for us, and they've been relatively successful throughout the state. We would love to see it get better. We know that more people are on Medicaid after the pandemic, so it's really important that we pay attention to that and the access in all areas of the state. Again, right now, Care First employees, direct employees are not working on that. So my area does not work on it, but I'm happy to talk to the people who are conversing with the SkyGen. The adult pilot has some features that are nice, and they would keep people out of the emergency room if the patients went to see the dentist on the program. There's a small annual maximum, but that could probably get you through a year from at least emergency care, and that diversion would be great. We do have benefits, as you know, for pregnant and postpartum individuals. Okay, next slide. I have to let you know that our Medicare Advantage person told me we could add another box for the dual prime, the DSNP people. It would have everything at no cost with a $1,500 dental allowance for exams, prophies, x-rays, fluoride, palliative, restorative, endo, crowns, perio, dentures, and more. But for regular Medicare Advantage, we have our core program where we said there is no Medicare Advantage program that has no dental. We make sure people have access to preventive care. In the enhanced program, which a good 40% of the purchasers have purchased, includes exams, prophy, and restorative non-surgical perio and extraction. So that's really nice to see. About 20% of the Medicare Advantage purchasing population from the Care First programs have also bought onto the enhanced add-on. So the overall 100% who have purchased it, 40% purchased the enhanced And half of those, or 20% of the population, have purchased the add-on to get pretty much a comprehensive dental program, as you can see, even implants. So we don't want people, we want the continuity of care to continue. And if dental has been a part of someone's past, some of the stories that Dr. Romaine was telling, maybe that patient that you had who hadn't come in for 10 years could have purchased this plan and taken advantage of continuing seeing you on a routine basis. That's what I would hope. But of course, it's financial. Next slide, please. This gives you a little more of the detail behind the scenes. And right now, although I just told the story about Dr. Romaine's Western Maryland practice, we have just started in the market, and we have not yet been able to, we're testing the market. We're trying to get it where there's the greatest volume of need, as you can see by the counties pretty much in Central Maryland. I did get a little additional information from our Medicare Advantage specialist. And she did say our individual Medicare Advantage non-special needs plans are available to residents of Anne Arundel, Baltimore, Baltimore City, Carroll, Frederick, Hartford, Howard, Montgomery, and PG County in the state of Maryland. And we're not planning to expand those particular plans, but we're going to offer different types of individual Medicare Advantage plans in the future, and including additional counties in the state. And we're going to work on the network adequacy first. So we're contracting the dentist to be part of it. It's been successful when we put the effort in, which is just relatively recently. So I would anticipate seeing something different in 2023 because we already had to file. Our dual special needs plans, they're available to more counties: Anne Arundel, Baltimore, Baltimore City, Calvert, Caroline, Carroll, Cecil, Charles, Dorchester, Frederick, Hartford, Howard, Kent, Montgomery, PG, Queen Anne, Somerset, St. Mary's, Talbot, Wacomico, Worcester, all throughout the state. We want to expand into more counties in the future, again, once we have the network adequacy, because having a program and having no one to go to, it's a cart before the horse. Sorry, I got to keep my dog from barking. We just continue to plan to lower the cost sharing for the patients and add more coverage, really extensive coverage. And for all those reasons that were just stated by Chelsea, we know that it lowers overall medical care costs. We know that it provides diversion from the ER. We know all these things are really great. So we're hoping to lower all the patients' cost sharing, add more coverage across the dental spectrum, broaden access to the providers, and continue to promote the robust dental coverage that this is such a great benefit for Medicare eligible populations with that Medicare Advantage plan. So that's what we have here. Can you go to, okay, I think you have it. I think that the slide before kind of gave you the sense of what it is. And really we just feel very strongly that it's important to have dental in Medicare. We have to do it through Medicare Advantage. We're happy to do it, and nobody goes without at least getting a chance to be seen by a dentist if they purchase any of the plans. You can go to the next slide. This just pretty much encapsulates in bullets what I had previously discussed. So at the end, it's really all about how can we help? This is a task force that's looking to find ways to break the barriers. We want to make sure that people are getting the access. Do they need teledentistry? Do they need a mobile van? The kind of education that we need? Do we have to give it through the community members? Do we have to give it through the physicians? We have the ability to do more through physicians, through Care First, because it's a whole health company. So how can we do it? Can we grab patients in and get them through care coordination, making sure part of the coordination of that care is dental? That's one of the things I'm trying to champion right now. And of course, as Dr. Romaine knows, I'm very big into the ER diversion and creating incentive programs that will get the medical practitioners aligned with the dental practitioners, that Dr. Doring knows very well. What other volunteer projects can we do? We have a big focus on volunteerism at Care First. So maybe some of these ideas are things we can take into action as a leading healthcare provider within the state of Maryland. Any questions?
Thank you, Dr. Lerner. Appreciate it. And again, Dr. Lerner's presentations, I'll get to you second, Dr. Quammen, Care First being the largest insurer in the state, to get a sense of what a entity of that large will offer across different payers, with the payers obviously being distinct in terms of how it shapes the benefit design. So that's always important to take note. I mean, that's the one thing where we can control certain levers, make recommendations in that regard, and then some we are kind of outside of our sphere of influence. Dr. Quammen.
Just because I don't know a lot about, I'm a pediatric dentist, so I don't know a ton about Medicare and Medicare Advantage. So with the Medicare Advantage plans, so the seniors would be adding that on as like the core benefit, like you showed, and then like the different levels that they could sign up for, right?
Yes.
And so what's the basic cost of something like that to a senior that would want to join on, starting with a core benefit?
You know, I had pulled that information, and I didn't get quite the information I needed, and that was something I wanted to be able to present. There's definitely a differential in cost depending on how much added services you have, and you want to know basically how much it is. And of course, as a pediatric dentist, how would you know much about Medicare? But buying Medicare Advantage is an additional amount above and beyond getting the Part A of Medicare. The top level program, the enhanced with the add-on, is very close to the cost of when you buy it commercially for a group, if enough individuals buy it. And I'd hate to quote you a number and be wrong, but when we tried to design it, we wanted to make it so, like I said, there was this continuity of you're used to paying a certain amount, you're used to getting a certain amount if you have the comprehensive plan. The core program, what I didn't mention, because it's outside of dental, is that these Medicare Advantage plans have much more than dental. They have vision and hearing aids and all sorts of other things going on. So I wish I could give you the numbers, and I will see what I can do. I believe it's on the web, but it wasn't as clear to me as I wanted it to be for this group. But if I could take that as a takeaway, I will get it back to you.
Yeah, and the reason I'm asking is that, I just think, just for clarification on, is this a hurdle for, people to get, or, is this something within, seniors' wheelhouse that, if it's $15 a month, and it gets them basic services, is this something that's an attainable thing for, these people that are on Medicare, or is it something that's just so cost prohibitive that it doesn't allow them to get? I think that's what I want to kind of figure out when we're talking about it. And that's why I think for me, it would be important to understand those numbers.
Right.
Yeah, Dr. Koyman, Medicare Advantage is always going to be, reasons 37% of seniors pick Medicare Advantage over opt-outing of fee-for-service Medicare is because of the deductible, copay, so on, the multiple. I remember Medicare's design is off of Blue Cross Blue Shield benefit from 1965 in fee-for-service. And so there's lots of different copays and between 0, 130 days, 30, 60 days. So generally speaking, Medicare Advantage, the opt-out that seniors avail themselves of, at least 37% of them do, is that because the cost sharing in aggregate is less than that in fee-for-service. There's a little more cost certainty, $0 premium perhaps with a the deductible copay, but very small amounts. Either do the math, if you will. And then in return, what they do is they just have to accept a smaller network, generally speaking, than that which you find in fee-for-service. And because of the payment mechanisms of Medicare Advantage, which are set on the county rates, which plans bid against, there might be a little bit of extra that the plans get to play with between what they bid and what the benchmark is, that they have to roll back and inure to the benefit design, which results in dental, vision, hearing, things that you don't find in traditional fee-for-service Medicare.
Exactly.
Accessible, not every county in the country, I don't believe, and I might be misspeaking here, has a Medicare Advantage offering, or it might be that everyone does. And depending upon the county and the benchmark there could be 5, there could be 20, there could be a whole number. So seniors have this option. It just becomes a matter of whether or not it caters and tailors to their needs. Is there a doctor in their network? Is there a drug on the formulary? So on and so forth.
Right. I think one of the key things is what you just mentioned, Alex, is that the network is one of the reasons why people stick with. They have a dentist, they want to stay with their dentist. That's definitely it. And that's why you don't want to sell something where you don't have the choice, because my experience is that seniors or people who are established with the dental profession, unlike maybe millennials and younger, have a relationship with their dentist they don't want to lose. So we're dealing now, it's boomers and up. And I'm one of them. So I'll just say we like our person and we want to keep our person, and you'd hate to leave your person. So there's no point in offering something that's going to make somebody unhappy. The core program, while I don't have the actual numbers, is not very much at all. It is not cost prohibitive. But there are co-pays that may seem cost prohibitive. And that's why it's really important to get it very clearly messaged out so you're not buying blind. I think it's best, and I have not been as involved in it as I'd like to be because we were just rolling it out, to get out there and talk to groups where you can say, you know, you're going to go, here's your scenario. You're going to go to Dr. Doring and you're going to go get a cleaning and an exam and some x-rays. You're going to have to pay $30. They're co-pays. In your head, you could think a little bit like a DHMO, sort of like that, but it's in a ideally broader network. So in these 9 counties, we have a broader network and we haven't expanded it for that exact reason. But the cost prohibition would be probably something that really needs to be pulled out in front and center with the marketing to patients, so that they pick the correct thing. I'm trying to feed her all sorts of treats while we're talking.
We'll give you a chance to do that while we get Dr. Doring's question. Dr. Doring.
Thank you very much. I just want to acknowledge Dr. Lerner for her efforts and she works in a tower with medical professionals, and to unite medicine and dentistry together is a big plus. And we just did a course recently where we collaborated, and that's going to be ongoing. The Maryland State Dental Association has reached out with MedChi, and we're going to investigate programs together. But I also want to acknowledge, and maybe she could comment on some of the things during the COVID-19 when we were closed down. It was, or at least just seeing emergencies, it was certainly a trying time. And then to get PPE and get this office rolling again and to be able to see patients again, she was very instrumental in that. You may want to talk to some of the things that Care First did during that stage of the COVID-19.
Yeah. Well, thank you. And I'm heartened to hear that MedChi is paying attention. That's good. They've been harder to get a hold of. There were a couple things that we did. One, we checked with the Dental Association. We worked closely with the Dental Association, and we knew that the cost of PPE, first, it was really hard to get. Second, dentists were donating it to the medical side. And when it came time for dental offices to reopen, it was not only hard to get, but it was much more expensive. We worked with the actuarial department to try to get a supplemental fee to help cover at least part of some of the cost of the PPE and all the other tasks you need to disinfect the area, especially in the beginning of COVID. So we were able to come up with a PPE supplemental fee until such time as we could incorporate that back into part of the increase in the PPO fee schedule. So we recognized that there was a cost involved for doing business during COVID, and we so appreciated it. We knew that it had to be borne by the patients, the doctors, and also the carriers. So we wanted to do something with it. Another thing we did that actually didn't come to fruition, Charlie, that you may not know, is that that same community health and social impact group had a way of getting free face masks, and they wanted to give it to all the dentists, which was fantastic. But we had to get a couple of dentists to try it out because I just wasn't sure they really understood how dentists needed face masks. And it turned out that we had a few dentists try them out in their practice, and they said, no, these are no good. And so we didn't give it. So the good thing is they're thinking dental, and they understand that dental is different than medical, but they do want to find a little parity from one side to the other. So thank you for bringing that up.
I would make note to the task force. We're coming up on time, and I know that Dr. Lerner's dogs are not the only ones looking for dinner. So I want to ask a couple more questions. Anyone from task force have additional questions?
Please feel free at any time to reach out to me. I mean, Diane and Charlie know that you can reach me anytime and my cell number. And I absolutely am dedicated to making sure dental gets the attention it needs, and that the access to care, such an issue that it just breaks my heart. I feel that there's probably plenty of creative solutions that everyone can come up with, and I'm happy to contribute if I can.
Thank you, Dr. Lerner. Hearing no questions from the task force, Dean Reynolds, anything you'd like to add, or as we get ready to conclude?
No, not at this point, Alex. I very much look forward to our next meeting, and I'd like to thank our presenters. This was very informative.
Yes, again, thank you so much for that, for the presentations. Delegate Bagnall, anything you'd like to add before I make closing comments?
Yes, thank you so much. And I hope you can hear me. I apologize that I haven't been on camera. I've been on the road. Just an ask for the subgroups. I know that this is a really challenging time, that we're very time constrained. But if we could commit to trying to get something on the calendar by next week, and commit to trying to meet at least once, even if it's a Zoom, to touch base before that meeting on the 18th. I think it would go a long way to really energizing the work going into the session.
Delegate. And to that end, our next meeting, we have 2 meetings this month, and I do again appreciate everyone taking the time the late afternoon, early evening to accommodate our presenters and to kind of get into the weeds. Our next meeting will be on the 16th of December, Thursday. That is our traditional third Thursday. We will meet from 10 to noon. And at that time, we will have additional speakers. Your agenda will be out shortly. We'll look for the report out from our various subgroups, and we will take votes on our cadence for meetings come January, and then discuss our work plan given the fact that session is upon us. And then look to our threshold events, which is an interim report, which is due in late spring, that we need to start crafting. So as things start to come together. So with that, any last comments or questions before we close out for the evening? Okay, again, I thank the task force members and the support staff, as well as our presenters, for their time today, and I look forward to seeing you all on the 16th. We are adjourned. Thank you.
Thank you.